Hello, ladies and gentlemen, and as chair of the International Working Group for Disorders of GI Motility and Function, it is my pleasure to introduce this satellite symposium on the diagnostic testing of esophageal motility disorders and gastroesophageal reflux disease. The presentations that you are about to see were first delivered at the FNM 2020 in Adelaide, held in April of this year. The faculty is delighted that our President, Kazim Aziz, and Chair of the Scientific Committee, Adam Farmer, have invited us to present also at the ESNM 2021. The costs were covered by an NIH grant held by John Pandolfino. Commercial sponsors were not involved, and the information that you are about to see is relevant to all those using high-resolution manometry equipment, whatever the manufacturer. The International Working Group is an organization that is a common interest group for individuals, physicians, practitioners involved in the investigation and treatment of functional gastrointestinal symptoms. As far as the esophagus is concerned, and this is where it all began, this involves transport of food from the mouth to the stomach and the prevention of reflux. And it has become clear through seminal work by Don Castell and others, that it is really only when these functions are disrupted that symptoms occur. Motility alone is not enough, but motility gives us an impression, an idea of the underlying pathophysiology. That's why it is so important. And there's also why endoscopy and radiology, although essential to exclude organic disease, do not provide a clear diagnosis in the majority of our patients. What we need is an exercise test for the gastrointestinal tract, and that is what manometry provides, and also pH impedance measurements in people with reflux symptoms. This became important when we moved from the era of conventional manometry, which failed to address many of these issues, to the era of high-resolution manometry. It was clear that for many diagnoses, conventional manometry findings failed to explain the cause of symptoms, and that the diagnoses were in fact subjective, based as much on clinical presentation as on the objective results of pressure recordings. More data was required, and this was quite simply provided by increasing the number of sensors. Just as important, however, was how this data was presented as a topographic plot, now in honor of Ray Klaus, one of the first to introduce this technique, Klaus plots. These give us a visually intuitive visualization of the motility as it passes from the pharynx down to the stomach. Similarly, in the realm of gastroesophageal reflux disease, we moved from simple pH studies to combined pH impedance measurements that provided not only measurements of acid reflux, but also the movement of food and fluid down through the esophagus, but also up, back from the stomach into the esophagus, non-acid reflux, gas, whatever was moving, we can now monitor. Just as important, perhaps, in other individuals is the ability to monitor over very prolonged periods of time using wireless measurements such as the Bravo capsule. This work, of course, required the involvement of many individuals, from the development and validation of pH studies in the 70s to 80s, to high-resolution manometry in the 90s and noughties, to the first clinical HRM studies early this century. The foundation of the HRM working group, as it was called then, followed a meeting between myself, John Pandolfino, and Ariane Bredenord in Paris. We went back to our bosses, got them involved, and soon we were meeting to agree the principles of the Chicago classification. Shortly afterwards, at the Ascona meeting in 2011, it was agreed to expand this process to include gastroesophageal reflux disease and other technologies such as anorectal manometry. These were published in a series of articles, starting with the Lyon classification in 2018, and the further iteration, the fourth iteration of the Chicago classification in 2021. We base these classification systems on certain principles. First, the objective pressure measurements, metrics used have all been validated against objective gastrointestinal function, such as bolus transport or the occurrence of reflux events. They have been refined in recent years by the results of many clinical outcome studies. The diagnoses are organized hierarchically, starting with esophagogastric junction dysmotility, such as achalasia, and then also moving to major motility disorders that are never seen in health. The reason for this hierarchical organization is that if the gastroesophageal junction is not functioning, then food and fluid passage cannot be normal, even if peristalsis is maintained. More recently, with version 4 of the Chicago classification and also the Lyon classification, it has become quite clear that certain borderline cases require confirmation by additional data, whether that's symptom association, imaging, or modern technologies such as EndoFlip. This here is the Chicago classification version 4. This will be presented to you, helped by my chair, Peter Kahrilas, who is professor of gastroenterology at Northwestern University in Chicago and one of the main instigators of this process. You will see the hierarchical organization is maintained, and that, as I said, inconclusive cases now must be confirmed by the results of additional manometric tests, such as the inclusion of a solid test meal, but also imaging and EndoFlip where appropriate. Here, the Lyon classification version 1, which will be presented to you by our chair, Professor Daniel Sifrin of the Queen Mary University of London, and previously of Leuven University in Belgium. Here we also see the hierarchical organization, the acceptance that multiple investigations may be required to establish a really solid diagnosis on which treatment decisions can be based. All of this has been published in dozens of publications now. The key references, the Chicago classification, has been cited more than 3,000 times since it was first published in 2009. And already since 2018, the Lyon classification has been cited more than 550 times. These have really changed the way we talk about these investigations and the way we treat our patients. Progress has been made. We now are in a better position to understand the pathophysiological basis of abnormal esophageal function and symptoms. We're getting insights also into disorders of brain-gut interaction, such as functional heartburn. Using this information, we can provide our patients with a meaningful explanation of symptoms, and we can also phenotype them so that we can direct them to the most appropriate care. In the ultimate conception of all of this, we simply wish to improve outcomes and quality of life for the people coming to us for help. So, with this in mind, I hope you enjoy the upcoming Satellite Symposium. And looking ahead, I hope you can join me at the Ascona 3 conference at the beginning of May 2022. You can contact me for information about this event. Thank you very much for your attention.
Well, hello. Welcome and good morning, afternoon, or evening, as it may be, to this symposium on the Chicago Classification version 4.0. Diagnostic Testing of Esophageal Motility, State of the Art, 2021. I'm going to be your host for this. I'm Peter Kahrilas, coming from Chicago on a very cold afternoon, I might say, but I hope it's better where you are now. By way of introduction, we should review where we were with the Chicago Classification version 3.0. This was a document published in 2015, and it has lived for a good 6 years now. It looked at the Chicago classification as a hierarchical analysis, starting with the IRP and sorting out disorders of EGJ relaxation. Those were achalasia and EGJ outflow obstruction. Once that was determined, one moved on to look at peristaltic dysfunction. And the major motor disorders of, or the major disorders of peristalsis were DES, jackhammer, and absent contractility. There was then a fine line drawn to minor motor disorders or minor disorders of peristalsis, and these were ineffective motility and fragmented peristalsis. And if all of that was okay, it was declared as normal. So what went wrong, or what could be improved upon, I guess, is a better way of looking at it. The working group, comprised of many individuals from around the world, looked at this and spent 2 years of real and virtual meetings to analyze how one could improve upon the Chicago classification version 3.0. So we had 52 international experts. These represented 5 continents and 20 countries, 6 neurogastroenterology and motility societies. And well, it's been 6 years. There were 7 areas targeted for improvement as we contemplated Chicago classification version 4.0. We could develop a standardized HRM protocol because there was none at the time, and people were doing this testing in many individual ways, reminiscent of motility prior to high-resolution manometry. There was room for refinement in the achalasia diagnosis. Probably the biggest single issue was in clarifying EGJ outflow obstruction and what criteria were necessary to meet this diagnosis and what it meant. The DES diagnosis could stand some refinement. Hypercontractility could be clarified. Ineffective motility was always an issue. No matter how you look at it, the argument always, or the discussion always migrates to IEM, what it means, and how to define it. And finally, there was no formal discussion of EGJ barrier metrics in version 3.0, and we wanted to include that in some way in the evolution of the Chicago classification. So looking at these 7 target areas, subgroups were formulated from the 52 representatives from around the world, and each subgroup was assigned one of these 7 points, and the task was to write a technical review of the material, which would be published in NGM along with or shortly after Chicago classification version 4.0. And in this symposium, we're going to discuss the standardized HRM protocol, the refinements of the achalasia diagnosis, EGJ outflow obstruction, DES, hypercontractility, IEM, but not metrics. Because while we could come to some reasonable agreement on all these others, the discussion of EGJ metrics proved to be rather preliminary, and the technical review is actually now in press in NGM, but will not be included in today's discussion. So having said that, this is the publication of Chicago classification version 4.0 in the current issue of NGM. Those are the authors. This was a monumental effort. And just to summarize what's new in this relative to version 3.0, further manometric and non-manometric evaluation is required to arrive at conclusive, actionable diagnoses of EGJ outflow obstruction. This, I think, is a major difference because EGJ outflow obstruction was clearly the Achilles heel of Chicago classification version 3.0. And now there's an avenue toward clarifying that diagnosis by bringing in other diagnostic modalities and symptoms. So EGJ outflow obstruction, distal esophageal spasm, and hypercontractile esophagus must be accompanied by obstructive esophageal symptoms of dysphagia and or non-cardiac chest pain to be considered clinically relevant. There is now a standardized manometric protocol stipulating positions and maneuvers and challenges that can be used or should be used in certain circumstances. We've again refined the definition of ineffective esophageal motility. And we separate EGJ outflow from disorders of peristalsis rather than making them minor versus major disorders. So now it's one looks at these entities separately. As you'll see in the diagram as this discussion evolves, that one is on the left and one is on the right rather than one under the other.